I'm TJ Swope. I'm coming to you from beautiful Pasadena, Maryland. And we're going to dig into the data. And so we'll get into our first slide right now. Here's the famous iceberg. This is not the iceberg that sank the Titanic. This is the cost iceberg. And two parts of the iceberg. There's the part above water, which you can see it's very obvious, like the cost of the robot, maintenance, instrument costs, et cetera. The super obvious things I used to get really beaten up on when I would talk about cost 8-9 years ago. And then below submerged is the downstream cost savings that no one really talks about because they don't know their data, which is why if you don't know your data, you don't know what your downstream cost savings are for the hospital, and you can't plug yourself to your administrators. But things like decreased length of stay, decreased readmission rates, decreased complication rates, all those things I track and I know my data, and then I can compare myself to others and see where I stand and what potential cost savings I can offer my hospital versus someone else who may have higher rates of those particular issues than I do. And that all translates into financial numbers to the administrators. So again, the extended use program that just got rolled out, that is everywhere now. If you're on the X or XI, you're using the extended use instrumentation now. And there's been a cost savings associated with that, which I'm going to cover later in this talk. And then the slide won't end. It just keeps going. And so there's also your intuitive app you have now. This is great. We're going to cover this later in the talk as well. I can really, the stuff I used to have to drill down on my CSRs to get the data from them, now I can just pull up on my app and I've got all kinds of great data we'll talk about a little bit later. So all these things are going to go into this talk, and ultimately it's to have you track your data so that you can benefit from that, as opposed to having the data exist and just not even tapping into it, knowing what it is or using it. So also the My Case Data app, that's the other app. There's two apps. There's My Intuitive app and there's My Case Data app. So the My Intuitive app, that's free to everybody, and that gives your own data. And the My Case Data app is very specific. If you want to have your data tracked, you can enter your numbers into that app, and you can either choose to share that with Intuitive or not, but that data will be there, and then you can use that to keep track of your data. And we'll talk about that in a little bit. So there's all kinds of published data out there, over 21,000 peer-reviewed articles that involve robotic surgery. So there's a lot out there. Again, I talk about this study a lot. This was out of the American Hernia Society Aquatic Collaborative, comparing laparoscopic IPOM to robotic IPOM. And I think four really good things came out of that for me in terms of clearly I favor robotic, but there was lower seroma rates, lower surgical site infections, although not drastically different. And then more importantly, the ability to close the fascia was much more easy. It was up in the 90% in the robotic group, and it was almost half of that in the laparoscopic group. So really the robot allows you to close that fascia more easily. And then bowel injury wise too, there were 4 bowel injuries in the laparoscopic group and none in the robotic group in this particular study. Melissa Lipinska put this together out of the AHSQC as well, the American Hernia Society Quality Collaborative, and they matched 650 Da Vinci versus 650 lap ventral hernia repairs, and their conclusion was there's a shorter length of stay, fewer open conversions, and fewer visits post-operatively. So again, that conversion to open, that's a recurrent theme through all of my robotic procedures, and that's a big downstream cost savings. Inguinal, bunch of inguinal stuff out there now. This is the more favorable inguinal we're going to talk about. We'll also touch on some stuff that wasn't necessarily as favorable, but trying to be fair. This looked at as basically they dug into the clinical database and used codes and pulled up data comparing open, lap, and robotic inguinal hernia repair. And if you drill down on what they did, basically lap and robotic were more favorable versus open, MIS versus open. And then within lap and robotic, there were overall fewer complications in the robotic group, and overall minimally invasive had fewer narcotics, and that's been proven with my personal data as well. Here's another one. This is Carla Blanc shout out to Gene Dickens, and Tony Gonzalez, Reza Gamagami et al. And they looked at robotic versus open versus robot-assisted inguinal hernia. And again, also the MIS came out more favorably versus open. The narcotic prescriptions were significantly lower with the minimally invasive approach, both open and laparoscopic, but robotic was even more favorable than laparoscopic in terms of the need for narcotics, which, that's good. That's less pain from our patients, so that's a good thing. Cholecystectomy, I'm a huge fan of ICG. I love Firefly. I talk about Firefly all the time on the robotic surgery collaboration. And again, I see all these accessory ducts. I see them all the time. This is looking at ICG, and what they found was there were fewer minor biliary injuries. There were fewer conversions in acute cases. Again, there's another example of lower open conversion with the robot versus lap. And again, less blood loss, although I can't imagine blood loss is that big of a deal with gallbladder surgery. But there were really lower biliary injuries altogether, and they allowed them to see aberrant biliary anatomy, which normally you don't see. And that happens a fair amount. Here's some colon data. This is looking at intracorporeal versus extracorporeal anastomosis. And this is also what Barry Salke's also talked about with his data. But the intracorporeal anastomosis is associated with lower anastomotic leak rate, moving the extraction site from periumbilical to suprapubic decreases hernia rates. I have less pain with that. It's about a half day shorter return of bowel function and length of stay versus lap. When you can do that intracorporeal anastomosis and move that periumbilical extraction and sort of a hybrid open laparoscopic to straight up everything done inside the belly. Here's some bariatric data for you. I don't do bariatric surgery, but I try to include everything. So they drilled down on lap and robotic and compared them. The thought being that robotic, it's got to be way more expensive than laparoscopic. And it turns out that there is a trend towards lower length of stay with robotics versus laparoscopic, and that the supply costs are actually less robotically than laparoscopically. But until you drill down and know those numbers and compare them, you don't know. So you assume it's one way, but until you drill down and get your data, you just don't know. Again, these were not as favorable towards robotics. One was the Prove It, that was an IPOM study, lap and robot, and the other was the Rival study, and that was a robot transabdominal preperitoneal versus laparoscopic. Again, they thought that the outcomes were very similar, but there was increased cost associated with the robot, and it took a little bit longer to finish those cases robotically versus laparoscopically in these very small studies. Interestingly, in the Rival study, they did not note any ergonomic improvements on a laparoscopic tap versus sitting at the console comfortably. I just don't know how that's humanly possible, having done both, and that is the most unergonomic operation ever, that laparoscopic tap. So anyway, just some thoughts. So again, factors to consider: your experience, the program maturity, and the patient populations you have to deal with, techniques and approach. All those things factor into generating your data. But this is why it's important to know your data. So the only data you really ultimately care about is your own data. All these studies are great, but what am I doing? So how am I coming along? So your data, your truth. Here we go. So you can validate your data by collecting it. And so this is where that app comes from, the My Case Data app. I use the Excel spreadsheets. I've had them before the My Case Data app came out, so I have a whole system worked out, and I use Excel spreadsheets, and I track everything that way. But with the new My Case Data app, you can actually enter this, and you can choose to share it or not share it with Intuitive. That's your call. But then you can track and have all your data, and then when you need your data, it can be mined for you very readily. So how do you track your data? For me, I like to track data on Excel spreadsheets. I've been doing this before the My Case Data app came out. If I didn't have all that already set up and arranged and had a system working, then I would do this My Case data. I think it's super easy. You can choose to share your data with Intuitive or not. If you don't, they're never going to see it. And you can put it all in there, and then you can mine that data, and they can get that data back for you, and you can look at all complications and readmissions and all those things that I now know. You can just pull it up with your app and working with Intuitive. So it's a great gig and a great way to keep track of that stuff if you're just thinking about getting into tracking your data. So again, there's a whole host of resources available to you. I would completely hit up your CSRs for help with all this stuff. They can. There's a whole bevy of people at Intuitive that are happy to dig up and track data, and they've got a whole host of stuff that they can share with you. So support and analytics from Intuitive is great. They do a good job of supporting everybody. Great training, education. Courses, of course, those aren't happening right now in COVID, but they'll resume once the vaccine gets out there. So I think there's a lot of resources for you. You just have to ask and take advantage of them. Again, there's this whole MACA thing, the market access and custom analytics. Those folks, they're free, and they can really dig deep in your data and pull out some good stuff for you. And that's Intuitive, helping you out. So why do I want to know my data, right? Well, one, I want to know if I'm good or bad compared to other people, right? So what is my length of stay, 2 days longer than the average length of stay for a colectomy? If it is, then why is that? Maybe I need to start, changing how I take care of my patients and on my colectomies, or leak rates are really high, or the gallbladder, whatever it is. You need to know your data so you can compare yourself and see, am I way outside the mean? And if there is the serious deviation, then why is that way? And what am I going to do about that? And then you can do some inflection and work on making things better. Again, you will learn to talk to administrators, which is really at the bottom of our list of things I want to do. But ultimately, you will be able to engage with them in a way that you weren't able to before. And you can kind of speak their language, which will ultimately help you, I think. And again, knowing your data, I can really tell them what my downstream costs are. So that's a lot of data. Here we go. And if you say data, that's fine. I'm not sure which it is. I'll go with the Star Trek version and go with data. So here's my IPOM outcome. This is ventral hernias now. So these are my IPOM outcomes. And if you look at length of stay and complications, open is sort of the greenish color, lap is the yellowish color, and the robot is blue. And you can see length of stay and complication rates compared to national averages. And so since I'm less in those particular areas, that all translates into potential cost savings and et cetera. You can look on the right, and I track my recurrences, my conversions, seromas, all those things. I track all that, and that all gets factored into the downstream cost savings, since I'm not having those things happen as often as other people. Therefore, I'm saving money. Again, here's our TAP, robotic transabdominal preperitoneal ventral hernia outcome. Again, very similar theme. I'm happy to share this with you. My length of stay, my complication rates, consult times, all those are listed here. ETAP, same here. I'm pretty much just doing ETAP these days for most hernia repairs, although I will tailor it and occasionally do an IPOM or do some TAPs as well. But again, this is how I've been rolling lately. But again, here's my numbers. I think if I have to do a TAR, that consult time is a little bit longer, but without having to do a TAR, it's pretty reasonable. And again, I'm saving a fair amount of money doing these cases ultimately for the hospital. And when they see that, they really start to, they'll perk up when they see the money you're saving them. And again, I like that all these folks at 2 years report continued in core strength, except for one guy who said he felt about the same, but the rest of them all report improved core strength. I follow everybody for at least 2 years. Inguinals, that's tougher. That's all phone calls and not as robust, but the ventrals more intensely. So all ventral, if you combine it all and put it all together, you can see down there the estimated total cost avoidance, and down the lower middle, that's a pretty significant cost avoidance versus open and versus lap. I just don't have to deal with those lipocutaneous complications like I used to have to doing the big open repairs. Again, I track narcotic use across all of them. Again, these numbers are all relatively low anyway. The highest was like 3.3, and that was IPOM at 2 weeks. Still pretty low. You can look at the narcotic use on the right, average. ETEPs really don't have a lot of pain. That's a pretty nice repair. And again, we track the chronic pain scores, and chronic pain rates are very, very low for these approaches, thank goodness. Gallbladder. Let's talk about gallbladder. So, I've done a decent number of gallbladders. There's people have a lot more than I do, but I do track everything. And you can see across the board there, my numbers are pretty good. The one that stands out to me is the bottom there, accessory ducts. It's a 1.7% accessory duct rate. Now, I was taught that was much lower than that when I was a resident. So they're much more frequent. I'm able to see those ducts and avoid them using fluorescence imaging. And if I can't avoid them, I can clip them and not get a leak from them. So all that's good. I always firefly the gallbladder bed when I'm done to make sure there's no accessory duct or leaking bile. I check my cystic duct stump on every case. And I much prefer to have the firefly than not have the firefly. I can't do a talk without a surgical video. It's just not possible for me. So this is a surgical video. And this is just one of I've had two of these actually. This is the second one I had where it came out the edge of the liver. I ended up having to clip the other one as well. So I've had two of this exact type of accessory duct, two of the 8 that I've seen. Maybe the cardio would have held there, but I think I'm avoiding all these little micro leaks. So bio leaks can be expensive. No one likes to have a bio leak or a bile duct injury. Both of those add significant cost onto the cost of the gallbladder. So people say it's just a gallbladder, but that, as you know, is never the case. So these can happen on little skinny people with biliary dyskinesia, or just a horrible acute gallbladder. So the firefly, I feel completely comfortable operating with that, and I feel a little bit naked operating without it, as proven by this slide right here. They took and the patients that can't get ICG, those that are allergic to iodine, I operate them without the firefly, and they also subsequently the folks I can use firefly on, and they compared those times, and across the last 3 years, I've been significantly quicker with the firefly, because it's a time saver. It's like operating with the GPS right there. I can just toggle back and forth. I check the gallbladder bed at the end to make sure there's no oozing or accessory ducts, check my cystic duct stump to make sure there's no bile leaking from that. Very effective. Inguinals, done a few, over 1,000 now. Again, I don't have no idea what my recurrence rate is at 1 year. I know that I know of 2 recurrences, and I know there's more, but to the best of my ability to track these people, there's 2. And I know there's more. So we call every wait in 1 year, and the folks that actually answer, then we drill down on them. You have any issues, any bulges or anything, and they could say, no, they're fine. And they could have a recurrence. I understand that. But to the best of my ability, I know of 2 recurrences at a year. Some chronic pain, very low. And don't see that very often, thank goodness. A few seromas, a little bit of postoperative urinary retention. We don't see much of that anymore since we limited the fluids to about 700 for the case, and we reversed with Sigamidex and try to stay in the pre-transversalis fascia plane around the bladder. 2 bowel obstructions. One was a rent in the peritoneum that I didn't know was there. The peritoneum was bowed out at the end after I closed it, full of air. And then there was a rent at the very bottom of my triangle of doom dissection, and the bowel just slid right up in there and caused the bowel obstruction. So I had to go back and pull the bowel out and close that little rent in the peritoneum, which is why now I aspirate the air out of the preperitoneal space. I got that whole sort of trend started, and it came out of this complication basically. And the other one was a guy that presented twice in 6 months with sort of a distal small bowel obstruction. He had a big, giant hernia in his right scrotum, and his cecum and everything was down there. So he fixed it, but he just scarred it in a weird way. So I just mobilized his cecum for him again, and he did fine after that. One ileus, and kind of an oddball guy. Again, this is my inguinal pain scores. We do track everybody, and our pain scores are pretty low. Everyone we can get a hold of, we get pain scores from. Very little narcotic use. That number continues to slowly go down over time as I get more and more experience. Again, here's some colon data. So Reza Gamagami and Sandy Vijan and myself, we combined, this is all colons, this is not left or right. And we just pulled our data and compared that to NSQIP. And this is our data. And it's, I think, pretty good. We compare pretty favorably across the board to the NSQIP numbers. So pretty happy with these numbers. This is just a random 500 some cases of just the three of us. But that's pretty good data there from us, I think. Again, this is at my institution and looking at complications, length of stay, home health, all those things, readmission rates. So bluish is the open repair, lap is yellow in the middle, and robot is sort of purpley to the right there. And length of stay, better laparoscopically than open, but even better robotically. This is all colons. Who needs home health service? Again, pretty good number of open people do. Lower, much better for laparoscopic, but even better robotically. Complication rates, again, better lap, even better robotically. And readmission rates also better laparoscopically, but even better robotically. And these are all downstream cost savings. The part of the iceberg that's below the water, right? So let's get into cost a little bit. This is hot off of the desk of one of our financial guys at my hospital, and we basically drill down on these common procedures. And I say, what's some cost data I can give for this talk? So this is our average total cost per case, and in the left middle, that's 2019. Fiscal year 2020 is middle right, and then this last however months our year starts in July, so July till now. So again, you can compare 19 with 20 for colectomies, and across the board you go lap, open, and robotic highlighted in yellow, and I'm cheaper robotically. Lap, open, and robotic. For whatever reason, last year I was a little more expensive. Not sure why. I stopped using EEA staplers and I hand sew everything now. I'm not sure, but that's colon, so pretty favorable there. Cholecystectomy, same thing. Charges much cheaper robotically in 19, still much cheaper robotically in 20, and cheaper robotically this year as well. Again, these are numbers generated by my hospital. I have no influence over these numbers whatsoever. Inguinal hernia cost, again, lap, open, and robotic, pretty favorable. Robotically, I'm coming in cheaper than lap, a little more expensive than open, but I don't think I can beat open on cost for an inguinal hernia robotically. Venture hernia, again, I'm pretty favorable once again in 2019, and again, still pretty good and very competitive open and lap in 2020. So you say, well, that still seems like a lot of money, especially for an inguinal hernia. Why would I use a robot for an inguinal hernia? That seems excessive, and you're not a good steward for cost containment. So I drilled down, and our hospital considers the robot a technological investment for the future of the hospital, technology investment, like an angio suite, like a CAT scan or MRI. It all comes out of the capital budget. So they don't count the cost of the robot towards the cost per case. That's a separate thing that comes out of the capital budget. So they don't count that. But if you did count that and you amortize that, it's about another $327 a case at our institution if you did that. So if you take that and you say, well, there's 324 million people that live in the United States, and Aetna insures 46 million of those people, then that's 14% of the U.S. population that Aetna insures. And there's about 750,000 inguinal hernias, so roughly Aetna has to cover about 105,000 repairs a year. So if you take that and you times it by the $396, whatever that number is for amortization, it's about $42 million they'd have to pay extra to have these things done robotically. And you're like, wow, that seems like a lot. Like, you're not a very good person to do that. And so if you take that number and then you divide it by the 46.75 million people that Aetna insures, it's about 89 cents per person, or about 7 cents a month per person to do the best repair I think I can do for 105,000 people. And this is not including the offset cost of lower recurrence rates and chronic pain rates versus an open repair. So that guy on the right there, he's a pretty happy guy, because if you take his salary at $41,676,887 in 2016, and you divide that by the 46 million people that Aetna insures and divide that by the 12, and ends up people are paying 7 cents a month per person just to pay his salary versus me doing the best operation I can do for 105,000 people. So again, all things in perspective. Stephen Hemsley, he's down there. He doesn't look happy because I think he only made $33 million. That's why he's very offset looking there. I'm sorry for your loss, sir. That's tragic. Oh, here it is. Yeah. So 7 cents a month per patient just to pay that guy's salary. Really? Okay. So how do you access your data? Me, I track my own data, but if you didn't, there's different ways you can do that. You can use the My Case Data app for your hardcore data, but there's other data you can get from the My Intuitive app. And I actually have the My Intuitive app. Actually, I have it with me now. Let me pull up. I'll show you. It's going to do a little Face ID. Boom. And there it is. And now I can look at all kinds of stuff. I can look at my case mixes, how many cases I've done, consult time, what's my average consult time on a colectomy, left colectomy, right colectomy, inguinal hernia, gallbladder. I have all this great data. And then I can trend that and see, you can see, am I getting quicker on consult time? Or my case lengths, are they getting faster? All that is available on the My Intuitive app. There's a little video of that. So again, you can look at case reports. You can check your times, your trends. I'm getting faster. This is great. How many am I doing? Here's my total number of cases. How long are these particular cases taking me? What instruments? So then you can break it down by case and like what instruments you're using for how long. That's how detailed this gets. So there's going to be a rollout for this in 2021, which is basically next month, 2021. So it'll be coming out soon. Very helpful. You can also look at benchmarks and data insights. So if you look at cholecystectomy, and this is all the cholecystectomies in the last 5 years, basically, they look at the average consult time. And as people go through their learning curve, and you can see that people's learning curves tend to get better. People are getting faster as they do more and more cases. Same thing with inguinal. People get faster and faster. Same thing with colectomy, same thing with ventral hernia, same thing with all of them. And the more cases you do and you get under your belt, the quicker you're going to be. That's less consult time. So you can track your average and see where you compare to other people along the way. The other cool thing is you'll be able to, because the XI and the X both have Bluetooth, so you can walk in. If you have your Bluetooth activated, it'll sync. And when you sit down at the console, your settings will all be pulled up for you, waiting for you, which is pretty cool. And you'll be able to check out clinical videos, et cetera, on the app. It's pretty cool. So extended use, this just got rolled out. We didn't have a choice. It just came our way from Intuitive, and they redeveloped their instruments, and they last longer now than they did before. So ultimately, there's a cost savings associated with that, and that got passed on to us, the consumer. So if you look at on the left side, that's the average actual procedure cost, and then that's that same procedure cost with the extended use instrument. So you're saving, a good amount of money per case there. And this is looking at your typical choices of instruments for inguinal, for up over here, for ventral hernia. Again, if you choose this combination of instruments, this is how much it costs. And some are more expensive and some are less expensive. But on average, on the left side there, you can see you're saving money versus what you were before the extended use. Same thing on chole. Again, saving money. Again, I'm more in that $630 range. So I'm pretty cheap with my gallbladders. And for me personally, in 2019, the cases that I did, if you've exchanged the instruments that I used with the extended use instruments doing the same operations, it would have saved roughly $40,000. And that goes to the hospital. So it'd be nice if it went to the surgeon, but it's good to see savings going on and Intuitive working with the hospitals now and passing some cost savings along. I like to see that. Again, the quadruple aim, administrators love this thing. You're looking for better outcomes for the patients at lower costs with improved patient experience and improved provider experiences. Again, you really got to drill down and get your team going, share your vision with the team. work with administration, let them know what is you want to do with robotics and crunching your data. You can share that data with patients. If you want, you can say, well, I've done over 500 gallbladders robotically, and that's a large experience, and patients like to hear that. So the Quad AIM is an administrative tool that's become very popular, and so it's good to be familiar with it. Additional resources for you. I'm obviously a big fan of the robotic surgery collaboration. Yusuf Kudzi and Gene Dickens and I run that, and that's a great resource for folks that are on Facebook and you're a robotic surgeon or you're a first assists administrator. We'll let everybody in there, and you can learn a lot about robotic surgery on that group. SAGES has a robotics forum as well. That's great. International Hernia Collaboration, you can learn a lot on that. Hernia in America, that's a great program. Again, the other thing that's going to be coming down the pike is going to be virtual telepresence, where you can do a virtual observation. Our hospital's setting up for that right now. So, you could be hanging out in Vegas and in your office and then be in the OR with me in beautiful Baltimore, Maryland, and do an observation that way. So we're trying to make lemonade out of lemons currently. So that's how that's going to go. Hernia Night in America, and we talked about that before. Hernia U, all good things. So, and lots of training in person once this pandemic is corrected with the vaccine, hopefully soon. So a lot on data. So again, I collect your data, analyze it, make adjustments, recollect it, wash, rinse, and repeat. And it's the same thing. You just got to go through data periodically. I go through it about every 2 or 3 years, and I drill down again and see where I am, and am I still making progress. Intuitive is a great resource. Talk to your CSR. They're a good asset to you, and they can help you track your data and really push you along that way. Obviously, there's a bunch of us. You can get to us on the Robotic Surgery Collaboration. And there's a lot of very good robotic surgeons on there that are happy to share data and tips and tricks with you. And then my mantra, of course, is get good, get fast, and get cheap, right? You're not going to be good at first. You're going to be slow. You're taking you longer, but eventually you're going to get through your learning curve and you'll be tracking your data. So you know that, and you can see yourself getting faster. And ultimately, you can work on getting cheap on the downside. So I think that's it for me on data.